I thank Professor Tiwari and Dr. Lalit Verma for giving me this chance. This is the sequelae to the complications that we have been seeing. Well, let me start with a typical OPD screenplay that happens when we see a patient of CME. It will usually be referred by a cataract surgeon after an eventful or an uneventful surgery, 4 weeks. And this time I'll get a call from him saying, fovea looks unhealthy, there is no improvement with diffraction. And I am left to face this disgruntled patient. He would be informed, cataract surgery and IOL okay, some retinal problem exists and our specialist will see you. And the retina specialist will need to cool tempers, gain patient confidence and fend some difficult questions. He will say, sir, I was seeing better before surgery because we operate on 6/9. Anything wrong with the surgery? And he'll ask, will I recover vision? How long will it take to recover the vision? And he'll keep asking you this question again and again. Anything wrong with the surgery? Could we have avoided this situation? And how to manage this patient? I'll cover this topic under the following headings. We'll try to look at the causes of CME after eventful and uneventful surgery and try to get an evidence-based stepwise management. Cystoid macular edema is one of the most frustrating and common complication that one may face, and our cataract surgeons who are used to seeing 6/6 may find it very frustrating. And if you have an intraoperative loss of vitreous or a PCR, the chance of CME increases by 10 to 20 fold. There are some definitions that we should know. Angiographic CME, here the patient is asymptomatic but he will have a detectable leakage on the angiogram. In clinical CME, the patient will also have impairment of vision as well as the typical findings on FFA and OCT. It is important to note that the thickness on OCT correlates with the vision and not the leakage on FFA. Some more definitions: early CME and late CME depending on when the CME develops, and a chronic CME is one which persists more than 6 months along with the vision impairment. When you have a chronic CME, the cystoid spaces would fuse to form a cyst, and these patients would have poor visual acuity as well as prognosis. Coming to the management of CME, the diagnosis is easy with a typical history and typical findings. The main aim of the treatment plan is to answer this question: why this patient has a CME? So it could be operation related causes or it could be patient factors. Let us point fingers at ourselves first. Any peroperative surgical complication, whether he had a posterior capsular rupture, a vitreous loss, or iris tissue damage, a retained cortex, or decentered IOLs, all these have increased risk of CME. Also, all the complications that we saw now, the nucleus going down, the cortex in the vitreous, prolonged surgery, use of adrenergic drugs. And also what we have noticed is, in the event of a complication, the anterior segment surgeons usually don't change the medication schedule, especially when the operated eye is the second eye. The first eye being uneventful surgery, fearing patient comparison. They have to step up the steroids, they may have to add oral steroids, but they'll not do it. They can blame it on retina later. But the CME can also happen after a perfectly done surgery. Here, when we have to look at the patient factors in these cases, an elderly patient may have higher risk of CME. Also, the compliance with respect to the drops. Sometimes a 2 hourly drops can be mistaken as 2 times per day. Stopping the drops at 2 weeks after he got his glasses because he is seeing very well now. Drops given with the kit are over and he did not buy them later. And also, if the other eye had a prolonged inflammation or CME after uneventful cataract surgery, please review the previous eye surgery notes. Then you may get a clue, maybe this patient may develop CME and we may have to step up the steroids in these patients. Also, if the patient has a complicated cataract, traumatic cataract, A patient of glaucoma on prostaglandin analogs. Be careful, you may have to stop the drops and change out to other drops. Also look at the comorbid conditions like diabetic retinopathy, vein occlusions, RP and retromacular traction. Be aware that CME can also happen after a YAG capsulotomy. Coming back to our patient, this patient had a perfectly done surgery. His vision was 6/18. It was noted that the patient has occasional AC cells, IOL in place and a dull FR. But when we saw him on a good slit lamp with the room lights off, his AC reaction was 3+. This patient had stopped the drops after 3 weeks. So it is important to assess the extent of inflammation to individualize the medication interval and the tapering. As far as CME management based on evidence is concerned, there is no standardized treatment or prophylactic protocol for pseudophakic CME. There are no big RCTs with long-term follow-up. Coming to the evidence that we have, topical steroids versus NSAIDs. There is limited evidence for topical steroids. There are basically case series, while for topical NSAIDs you have multicentral double-masked RCTs. NSAIDs are better than corticosteroids in head-to-head comparison. The drops that were compared were fluoromethanol and betamethasone. The combination treatment has synergistic effect. As far as which NSAID is better, the penetration into the anterior segment, the ketorolac is better than bromfenac and bromfenac is better than nepafenac. The ketorolac has significantly greater aqueous concentration. And coming to the better PGE2 inhibition, again ketorolac scores over the other two. In another comparison, the ketorolac was found to be significantly better than nepafenac in terms of patient satisfaction, compliance and post-operative pain control. And this Prescribe International said that nepafenac is a new drug after cataract surgery. It is just another NSAID drops, no better than the other NSAID drops, and it is less convenient to use. Coming to the management recommendations, correct preoperative evaluation is important. Divide the cases into normal and high-risk cataract patients and start the prophylaxis, and for a high-risk cataract patient, adopt a separate therapeutic scheme. You may have patients with all these combinations, and if you have glaucoma, patient is on prostaglandin analogs, stop them. If the uveitic patient is there, start a good perioperative steroid cover and slowly taper the steroids. And if you have macular edema associated with CRVO, BRVO, consider an anti-VEGF agent along with the cataract surgery. Coming to the stepwise management approach, the mainstay of the treatment is still topical corticosteroids along with the NSAIDs. Give it for 6 to 8 weeks time. You can, if it doesn't work, then you can think of giving a subcutaneous posterior injection. And then it still doesn't work, you can give a 1-month trial of oral acetazolamide, and then you should consider intravitreal injections. And for some situations, you may require surgery for persistent inflammation or a vitreous incarceration. Coming to the late CME, the treatment approach remains the same. This patient was noted to have CME 1 year after the cataract surgery. Along with topical steroids and NSAIDs, he settled down. Coming to the chronic CME, if it is refractory to the topical medication, one may have to use periocular steroids, intravitreal steroids, and anti-VEGF agents also have been tried. In patients with DME, intravitreal is said to be better than periocular steroid. But be careful in chronic CME. This patient was 7 months post-cataract surgery, 6/18 vision with a multifocal IOL, not responding to topical medications. Oral steroids were started but not well tolerated. And we gave intravitreal IVTA, vision improved to 6/6, but 4 weeks later the vision dropped. And we looked carefully, the patient had a fluffy material, filamentous material at the edge of the iris, like you can see here. This patient had developed a fungal infection. The chronic CME may also have a poor response, especially one has a VMT. Do a good OCT, see for point tractions, and these patients would require surgery to be done. Coming to the summary, the topical corticosteroids and NSAIDs are the mainstay of treatment. NSAIDs have the highest level of evidence. You can consider the injections if these don't work, and this is the stepwise management that you need to do. Thank you very much for your kind attention.